smart scientists at Novo Nordisk, Lilly and some of these other places have found other ways to kind of modify human GLP-1 or the structure of it and have them have effects.
This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. All right, so this week's episode is titled Weight Loss Wonders, Getting the Skinny on GLP-1s, featuring Dr. Spencer Nadolsky. We're coming here live again. I don't know if it's from the same couch, Justin. No, it's not the same couch.
Not the same couch. Similar couch. We've recorded in the Palazzo before.
But we're in Vegas. We are in Vegas.
Palazzo.
Yeah. We're in Vegas here for the health conference, actually. Here representing the Man Up Podcast. But we're very lucky to be joined here by Dr. Spencer Nadolsky because we're going to talk about some great stuff, the stuff that people are talking about, GLP-1. So, Spencer, for all our listeners who don't know you, can you tell them about yourself and what got you so interested in obesity and weight loss?
Yeah, I grew up in an athletically and academically minded family. My dad was a wrestling coach and biology teacher. My mom was an elementary school teacher. Really big in academics, but also athletics, and used basically nutrition and exercise science to get good at sports. State champ wrestler, all-state football. Went to college, ended up wrestling at UNC Chapel Hill, did pretty well there. Went to med school. Everybody's like, you're going to be a sports med meathead guy, like ortho. I was like, oh my God, I hated it. I was like, I don't really care about the bones and whatever. It's cool, but like, and they're like, oh, you could do sports med though, like performance. I'm like, I don't really care about getting people like a 400 or whatever bench press. I was like, I just want people to like work out if they don't. And so then people are like, oh, what about obesity medicine? It really wasn't a specialty back then, though. It was kind of new and emerging. There was a few conferences I'd go to, and basically everybody gave everybody phentermine, which is kind of an amphetamine-like, not addictive, but amphetamine-like type of drug. And so I was like, this isn't really much of a specialty. It wasn't until kind of these newer agents coming out, it really became, kind of embraced as a biologic type of thing that we can do something about. So the first like GLP-1 made for obesity was 2014. And that's like right when I got out of residency, did a specialty in obesity medicine. There's no fellowship. It's like an extra certification you do CME for. So I'm board certified in obesity medicine, but it's not like a fellowship thing. So I did family medicine, then did this, and then something called lipidology. So it's like cholesterol metabolism type of thing. But that was like 2014, so like just over 10 years ago is really when the boom for using these for weight loss came out. It wasn't as effective back then compared to now, but that was kind of what made it interesting. Really into nutrition, exercise, but it's frustrating when you're talking to patients and it's like I know what to do, I just can't do it. So that's what the medicines kind of came in and really make it a lot easier to help them do it.
That's so interesting. By the way, what position were you for football?
I was a fullback.
You look like a fullback.
In high school.
You're pretty tall for a fullback, honestly.
Yeah,
you're taller than I thought in person.
I know, you never know.
I don't know. I'm like a fucking midget. I was an all-state inside linebacker.
Oh,
honestly.
nice. There you go. Yeah, so I'd go and try to blow you up. Yeah. But I was also a defensive lineman. But in college, it's like, those guys were like a lot thicker. I could have.
UNC.
I got up to like 265. But I went to Michigan State to play fullback. It was a weird story, but basically the coach got fired. The new coach that came in did a spread offense, got rid of the fullback position. And I'm like, what am I going to do? Like, go play linebacker. And I was like, man, I'm not going to beat these guys out that have been doing this forever. No way. So then the wrestling coach at Michigan State gave me a scholarship. I was like, man, I'm going to go try to be Bo Jackson and play both at UNC. It had this whole scheme of trying to get in-state residency to go to East Carolina because it was the cheapest med school in the nation. Then I didn't even get into East Carolina.
Damn.
It was a whole. I don't even know what I was thinking back then. But anyway, I was a defensive lineman. But I was like, man, I got up to 265 for wrestling.
Dude, that's
and
big,
maybe I could have
man.
played D line at that weight. But even still, I was still probably small for a D line.
Dude, I was 235 pounds.
Oh, you're
235 at your
I was
height.
235 pounds at 5'8" on a good day.
God.
I don't
like
know
a
how
bowling
I could-
ball.
dude. I don't know how I could move, man.
You just
Cam
just
Scataba.
No,
throwing you in there.
Let's hopefully they win today, but we're recording this on a Sunday. All right, so like obviously you alluded to the GLP-1s, and I think we hear a lot about them, but I think a lot of people don't even understand exactly. Like you hear about them doing all these things. People don't understand what they actually are, how they work, and what they're doing for you.
Yeah, very simple. So glucagon, like peptide 1, natural hormone that comes from our intestines, broken down though very quickly within a minute or two by our own enzyme DPP4. So the story is back in I think the 50s or 60s. I never get it right, but they had people drink glucose versus injecting glucose straight into the veins, and they wanted to measure insulin response. And I would think that if you injected glucose straight into the veins, it gets right to your pancreas, it would shoot out the insulin much more and quicker. But it turned out that drinking the glucose had a bigger insulin response. So they called it this incretin effect, or like a intestinal secretion of some sort of hormone effect. There's something about ingesting something that had a bigger response than just putting it straight into your blood. And then over the years, they were trying to figure, well, how do we figure out what are these incretins? And then in the 80s, they started discovering them, and one of them being GIP and the other one being GLP-1. And that was in like 87 or something like that, GLP-1. Problem is, though, they're like, how can we make this into a drug type of thing? You give it, you're breaking it down so quickly, right? So actually, I was just at a hockey game last night. Do you know the Golden Knights, the Vegas
Yeah,
Golden
you went.
Knights?
Oh, that's cool.
And
That's a great stadium.
they had a mascot there. You know, they have their night out there, but they had this other mascot, Chance. Do you know Chance?
No.
I was like, oh, it's a dragon, because they have a dragon up there. And the fans in front of me, because I don't know anything about them or hockey or anything. I just like, this is cool. People are fighting. I like hockey, but I don't really know anything about it.
Yeah.
That's a Gila monster. And I was like, that's a Gila monster? I was like, like the little lizard venom. And that I was like, so that's what the first GLP-1 was based off of.
Oh.
The venom of a Gila monster.
Wow.
It's Gila. And I was told it's Gila, not Gila monster. Anyway, I don't know if that's true or not. But I thought it's a Gila monster. Anyway, so it was kind of an interesting story. This endocrinologist in the VA was trying to, I think he had a project of some sort to kind of come up with some sort of scientific discovery, just to see what you can find. And it was the Gila monster, these things only eat like a couple times a year or something like that. So like, that's kind of interesting. Started studying them, and it just kind of serendipitously found that 40% similarity with this component in the venom compared to human GLP-1. So when they studied it a little bit more, it was resistant to our own enzymatic breakdown, the DPP4. Well, yada, 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 Big Pharma got involved and made it into a drug called Byetta or exenatide. So that was the first GLP-1. So these GLP-1 receptor agonists, not our own GLP-1, they've been modified in a way to prevent that rapid breakdown by our body. The first one was based off the Gila monster. You'll see that in line, like, are you kidding me? You're injecting this venom that's going to kill you type of thing?
Oh,
it was just a component of it, and of course it was similar. All the new GLP-1 stuff, they're not even based off that Exidin 4 is what it's called, the exenatide. But either way, that was kind of how it started. And then smart scientists at Novo Nordisk and obviously now Lilly and some of these other places have found other ways to kind of modify human GLP-1 or the structure of it, or even GIP and some of these other incretin hormones, and have them have effects. So with these GLP-1 receptor agonists, so they stay a lot longer in our body. So the exenatide, you had to do it twice a day. Then there was liraglutide, which you had to do once a day. Then obviously everybody knows semaglutide, that's Ozempic, or Wegovy, that's a once a week. And then tirzepatide, which is actually what's called a twin cretin or a co-receptor agonist, the GIP and GLP-1, and that's a once a week injection too. And these things, they're just going to get crazier and crazier the more they modify these. They just need to be studied well, but the longer they stay in your body, the more they can have the effects. And then the other thing is the way they hit the receptors may have different downstream effects compared to our own human GLP-1 too. So really interesting stuff.
That's fascinating.
It
Yeah.
seems like everything we learn comes from lizards, right?
Yeah,
Like,
that's true. The testosterone.
We learned that
Yeah.
testosterone, all the research came from lizards as well.
I didn't know that.
Yeah.
Oh,
so,
that's interesting.
So thank you to all the people who are
Lizards,
anti-reptile.
thank you.
I mean,
Yeah, let's go.
We're big reptile guys. Let us be the first to say that we're the pro lizard.
Pro
podcast.
lizard. Yeah.
The Lizard Podcast.
Yeah.
That's a good catch line. I like that.
yeah.
Lizard podcast. So wait, Spencer, you're basically saying that these GLP-1s have been around for quite a bit.
Like 2 decades, yeah.
So why now? Why have they, like, in the past few years we really start, like, it feels like 1 year, like over 1 year,
Yeah.
it just
Yeah.
got thrown
Blew
in our
up.
face.
Really?
Like, are you on this or are you not? Like,
Yeah. So the first exenatide, a few pounds of weight loss. But as opposed to like the other drugs that were out there, you got insulin. Metformin was okay. It's a weight neutral / negative drug. Some of the other drugs, like, so obviously sulfonylureas, where they basically put a supercharger on your pancreas associated with more weight gain. Well, this was like one that, this helps with weight loss. Wasn't much though. Liraglutide a little bit more, and then and when they boosted it up in the dose, I told you that's the one that got approved for weight loss, but still around like 7% total body weight loss. It's not much. So if you're like 200 pounds, that's 14 pounds. It's not, on average, some people respond really well. Semaglutide, though, at the higher doses is like around 15%. And that's when, in 2021, when that first step 1 trial came out, that was the big trial so Ozempic was the lower dose version for type 2 diabetes. They then I hate to say rebranded. They got a different brand because Lord knows the FDA and all, big pharma want to make different brands, probably for monetary purposes. But they cranked the dose up. Instead of 1 milligram that was in Ozempic, that was 2.4 milligrams in Wegovy. And that was in 2021, the big headlines were like game changer. Because if we look at diet and exercise on average and like gold standard intensive training, behavioral coaching, it's around 6% or so total body weight loss over a year. So now we're talking about 15%.
It's crazy.
And then the next step is obviously bariatric surgery, which is around 30%. So it's like, wow, we have something right here that's, seems to more than double diet and exercise by itself. Of course, they put diet and exercise with the medicine too, and then we don't have to jump all the way out over to bariatric surgery. So that was why you probably saw them like right around 2021, 2022. Yeah. And then tirzepatide came out, and that's around a 20 or so, 21%-ish total body weight loss. So now we're getting close to bariatric surgery in a medicine.
Wow.
So that's why it was a lot of people were using it off label as Ozempic, even at lower doses. But it wasn't till like the higher doses came out, and then people were like, what is this? And then and you got the Kardashians, you got Hollywood, and that's basically boom, boom, fire. And then TikTok, I was kind of part of the initial TikTok movement of these medicines. Because like I was like one of the first to just talk about it on social media.
You absolutely were.
Just basically like, I don't know, my patient just lost 50 pounds. I would make a stupid, the dumbest video and just be like, I don't know, I'm just basically talking about what happened to a patient. Just like hotcakes. Everybody's like, give me that tirzepatide. and so that's basically what happened. TikTok, social media, Elon Musk, whatever.
Yeah, no, it's fascinating. And, obviously everything you hear about are these benefits, right? Weight loss, your appetite's satiated. But when you're counseling patients, what are the risks that you're worried about? Because obviously this is where you've been online battling a lot of misinformation about these risks, about these ideas. Like you're saying, take these alternatives or whatever because these don't have these kinds of risks. So can you highlight to our listeners the risks involved with taking these medications? Yeah,
the by far the most common side effects and risks are GI related. So nausea, by far. Most people will feel some nausea. Even the trials don't show like most people. If you talk to my patient, like everybody feels just a little bit of it. They may not have reported it, but if you talk to them, like, I may have felt a little here and there. But nausea's most common, very mild for most people, moderate for some, and then severe is relatively rare. But you do see it where they're just throwing up. They can't eat anything. You try to make sure they can drink so they don't have to go to the hospital to get fluids and then admitted for a kidney injury or something like that. And those are the bad stories you hear about. Like, this will kill your kidneys. Technically, they're kidney protective, like chronic kidney disease. There's studies showing like, oh my God, we have better outcomes with these things. But like if you're not able to drink water and you just keep cranking up the dose and you're throwing up and not drinking, not a good thing. So GI side effects, number one, and it's nausea and vomiting. That's the thing we look out for most. Reason why you don't want to just keep putting people up and up on the dose. It starts at a low dose and it just keeps going up in increments. The labeling used to basically just say you got to keep pushing people up. So sometimes insurances will be like, no, you got to go to the next dose, and the person's like barely eating. You're like, no, we can't, you idiots. Like, what are you talking about? And then you have to do a special appeal process to make it's so stupid. But so yeah, don't go up, and you get like smaller meals, lower fat. So people will try to stress test it. We're like, well, shit, I'm on this drug. Why don't I just go try to eat some pizza now? Because you won't be able to eat as much. Yeah. So instead of eating a whole pie, you're going to be like, I eat a half a slice or a slice and be done. The problem is that fat that sits in their stomach and then goes through their intestines, likely from an extra slowing of the GI tract that happens with the drug. And now it might be stimulating other hormones that are related to kind of satiety and potentially nausea. I think that's one of the reasons. But either way, high fat diet with the medicine in the beginning, you can try it later, can cause a lot of nausea too. Next thing is constipation, constant. The nausea goes away over time, by the way. It starts high and then goes away. Constipation is pretty constant, though. Always want to get people to drink lots of fluids, eat a lot of fiber, stay moving. Beyond that, you got reflux, same thing, kind of slowing of the GI tract. Some people feel tired from taking it, and everybody's like, oh, it's because they're not eating much. And no, there's something about the drug that's doing something in the brain that can kind of make people fatigued for a couple days after the shot, and then they feel better the rest of the week. And that goes away over time. The things that people are scared about, though, are like pancreatitis. That was one of the worries with the Byetta, the exenatide in the beginning, because the drugs work on the pancreas and help actually preserve that beta cells, the cells in the pancreas that make insulin. So like, oh God, are these things causing pancreatic cancer, pancreatitis? Yeah. So far in these big meta-analyses where they take the randomized trials from all these huge trials and put them together and compare it to placebo, there's no difference compared to placebo. I've seen it though. I've seen it happen, and I don't know, like sometimes there's an increase in gallstones from the medicine. That one actually is a true one. And gallstones obviously can cause cholecystitis or a gallbladder attack, and then sometimes gets to the wrong duct and cause a pancreatitis. Yep. But either way, compared to placebo, there doesn't seem to be any difference in pancreatic cancer or pancreatitis. But gallstones, that one does happen. It's likely from the weight loss rate. Maybe there's something different about how it affects the gallbladder function. Not sure. People talk about thyroid cancer. It's a big black box warning on the label. And the thing is with that is it's a specific type of thyroid cancer called medullary thyroid cancer, if you guys remember from med school.
Barely.
Papillary follicular.
Medullary?
Yeah, it's a rare type, and it comes from the C cells of our thyroid. And in rodents, it was seen in rodents. So in the big black box warning, it's like seen in rodents, not in humans. Well, rodents actually have readily available GLP-1 receptors on the C cells of their thyroid. Primates, humans don't. So it's probably why we just don't actually see it when we look at the data. They're still monitoring because they're like, oh God, is this going to cause? So, that one is what people get scared about that. Everybody's talking about blindness right now. It's a specific type of blindness that was seen in one retrospective study last year in JAMA in type 2 diabetes patients that were taking semaglutide. Then the newest analysis didn't show it and showed maybe a trend for potentially protecting from the specific type of blindness. And I've had my brother's roommate from residency. He was an ophthalmologist. He's a retina specialist, so we always have him on like I don't know shit about the eyes. Please explain this to me. And it's a specific type of blindness where the blood flow maybe to the eye gets lower, especially overnight. So people with sleep apnea, and if your blood pressure gets too low overnight, there might be a decrease. So it's plausible that I see my patients. I have to monitor their blood pressure very closely, because otherwise their blood pressure is going low. They're getting dizzy when they stand up, passing out. You got to be careful. So that I don't think it's real, but it's possible. There's something there if you're not careful. Muscle loss is the big one that we hear
Yeah.
about. And that's where, like, my clinic, we actually are literally publishing. We just had a case series published. We look at it closely. I hired a renowned body composition scientist as my chief science officer, because I'm like, hey, man, like, again, another like, I'm into body composition, like, whatever, but like, it's like his field where he looks, he knows how to read the DEXAs and understand the differences of components of whether it's fluid versus muscle versus fat tissue or fat-free mass and all these different things. Anyway, based on the data that we have and what other people are seeing, it doesn't look like it's any different from like bariatric surgery or something like that. There was a signal in semaglutide on the DEXA scan where it looked like more fat-free mass was lost than what you'd expect, but fluid in our muscles can look like fat-free mass. So was there a diuretic kind of effect that, I don't know. Nobody knows. But in tirzepatide, the more powerful drug, that effect was gone. And then either way, we want our patients to lift weights and eat enough protein, right? So we did a case series where we looked at a few patients that did that, and they actually gained muscle while on the medicine. So, and we're doing a longer 100-person prospective cohort right now. Not everybody in there is lifting. I want them to all lift, but like, we're going to see, like, okay, those that lifted versus those that don't. We're going to kind of see. I don't know what's going to show up.
It's very interesting, though. It's important stuff. It's important to know. So, I mean, you've mentioned a lot of different GLP-1s. And my question then becomes, because I think a lot of patients come in and they hear all these different versions of these medications. Is it one size fits all? Are you prescribing a specific GLP-1 for a specific kind of patient? Or is it like, if you come in, you're probably going to start on this one and we have to see how you react? So how do you guide people on which GLP-1 they should be taking?
Yeah, no, that's a great question. So it's really, a lot of it's insurance based.
Yeah.
So if insurance says, so for example, the two big ones that you're going to prescribe are going to be Wegovy, which is that semaglutide, or Zepbound, which is the tirzepatide for weight management. You can get Ozempic for type 2 diabetes or Mounjaro for type 2 diabetes for the tirzepatide, but like, let's say it's just weight management. You're generally not going to do that Saxenda anymore, the liraglutide one. It's still expensive and it works half as well or even a third as well as the tirzepatide. So when somebody comes in, it's really like, all right, what's insurance going to pay for? And then really, like, I'm leaning towards a Zepbound every time, because even at the lower doses, you don't need to crank them up to the higher doses. It tends to be better tolerated, so less nausea. It tends to be cheaper on average if they have to pay out of pocket. And it's just better overall. So like, better side effect profile, more weight loss, but you don't have to get it all because you can stay on the lower doses, and more cost effective. However, I will say that Wegovy has been found. So in somebody with obesity, not type 2 diabetes, but obesity and cardiovascular disease, semaglutide or Wegovy has been shown to reduce cardiovascular, major adverse cardiovascular events. The study looking for at tirzepatide to see if that's happening, it's a different type of study. That's not going to be out for a year or two, so we don't know. I assume it's true.
Right.
I can't say though. So maybe if somebody has cardiovascular disease and obesity, you'd lean towards that Wegovy semaglutide. Otherwise, I'm all day Zepbound, and I don't even get paid by Lilly, the place. I was
Shout out to them. I
was on a Novo Nordisk ad board in the summer because I'm like, you know what? I never take big pharma money, but I was like, I got invited to do one of these things, and I asked my patients. I'm like, I'm pretty, because I like saying like, I don't get any money. I can just talk about these, but everybody was like, no, you should get money, and your haters are going to hate you anyway. So just take the money. And they're like, and then you go advocate for us to get the drug cheaper. So all I did at the ad board, where every time my turn came to talk, I was like, can you just make this like $100 or $200 instead of like $500 or $1,000? And they kept saying, we're not here to talk about money. I'm like, I'm here to talk about it. And like, that's what I thought. I think they got me. I think they're good. I may never get invited back.
Hey, you miss 100% of the shots you don't take,
right.
so you got to do it.
Right.
All right, so there's a lot of debate out there about, like, you know, if you stop the GLP-1 agonist, that you may gain the weight back. So there's discussion like, do you kind of stay on the meds? Like, when we talk about testosterone therapy, one of the things I tell guys is like, hey, look, there's a good chance once we start on it,
Yeah.
you're going to stay on it. So is that the same with GLP-1s?
Similar. So this is where the difference in kind of the paradigm of thinking of obesity has changed in the past few years. I mean, it's always been this way, but it's the way we looked at it, as opposed to thinking of obesity as just purely discipline willpower issue. Like, you just got to suck it up and eat better. Yeah, ideally, but unfortunately our bodies fight back when we try to lose weight. Our bodies fight back in ratcheting up our appetite more so than what we would be at that weight if we just never gained the weight in the first place. So when you go on the medicine, let's say you lose 20% of your weight. Let's say you're 300 pounds, you lose 60 pounds from tirzepatide, and you stop. You're like, all right, I want to stop. I've lost the weight. They've done this before with a placebo-blinded controlled trial where they put everybody on the drug, and then partially through the trial they randomize a portion of them to a placebo. They're still taking the shot, and boom, 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 most people regain the weight. And there's a portion. There's about 10 to 15% of people that keep most of it off. So there's clearly people that don't have this biological drive after they lose weight, or maybe they're just able to find ways to control their appetite. Hard to say. So most people will have to be on the drug long term. I always tell patients, like, look, you may not have to stay at the highest dose. You might be able to come down.
Yeah.
You may be able to go every other week, but think of it as like a blood pressure medicine. You start the blood pressure medicine, it comes down to whatever 140 over 90, and now it's 120 over 80 or whatever. And you're like, all right, blood pressure's good. Now, having said that, if that person weren't doing the lifestyle things before, let's say they were, and you put them on the drug and you take them off, they're going to go right back up. They're still doing the lifestyle. With the lifestyle, couldn't get it down. Well, let's say they weren't doing the lifestyle. You put them on the drug, then they started doing the lifestyle. All of a sudden, you wean them off, and you're like, the lifestyle is holding it at bay. So you do have, even with lifestyle alone, and you lose weight, you got to keep doing that lifestyle. Yeah. So it's kind of this concept of like chronic disease, chronicity of the thing. Same with, obviously, testosterone, but it's different because it's not like we're down. We didn't have a GLP-1 deficiency.
Yeah, right.
Although people think that like we must have a GLP-1 deficiency. It's like, nah, not really.
Yeah.
No, I think you bring up an important point that we talk about a lot, is like this concept of obesity is the same as concept with hypogonadism, in terms of people come in to see us and they're like, oh yeah, I have with known low testosterone, and they're like, my primary care, another doctor was like, dude, just go exercise and lose weight. And it's like, no, you literally have low T, like it's a vicious cycle. And it's the same thing that you're saying. It's like sometimes lifestyle can do stuff, but you have a disadvantage and you need that extra help. And there is a biological situation for low T, and obviously for obesity, there's a biological component as well.
Yeah.
And this leads to this lifestyle, which you brought up. I mean, these medications obviously improve weight loss, but lifestyle is truly one of those things that is important for everything that we do. So how important, when you're putting someone on these GLPs, is lifestyle in terms of your diet, especially exercise as well?
Yeah, so I always like to say it's kind of changed how we think about it, because the drugs are going to help you eat less, eat a lot fewer calories, regardless of where those calories are coming from. But the thing I notice about my patients is the patients that lock in and use the medicine for like a tool to then hone in on their lifestyle versus just, people, the thing is people will lose weight when they take the medicine regardless. Yeah. But the lifestyle comes in to minimize the side effects and optimize things in terms of like body composition, especially. Like if you don't resistance train, you're going to lose muscle. It's regardless. But you do that anyway if you just crash dieted without exercise anyway. You can go on a grapefruit diet or whatever the heck people are doing, whatever's going on the internet that I see.
It's crazy, dude.
Although the grapefruit's been around for a while.
Forever.
So like minimizing side effects, optimizing things, and really it's the body composition. And there's gotta be, I hope there's an effect of like eating a better quality dietary pattern and longevity. However, a lot of it does come down to the body composition. So like optimizing thing, that's where the lifestyle is key. But if people wanted to take the medicine and just lose weight and not do anything else, it'll work. But I have a feeling that people that go beyond that average weight loss, like some of those patients that I have that have hit like 50% of their weight loss, they
Wow.
are dialed in.
Wow.
It's awesome.
But they couldn't do it before.
Right.
But they it was like they talk about food noise.
The
It's
light
just
switch.
they just think about food all the
Yeah.
time. Like when are they going to eat? How much is it going to be enough? When they're at dinner, they're thinking about dessert. They're not even craving anything, but they haven't even finished their meal yet, or it hasn't even come yet. All these different things, and all of a sudden, boom, they can think, and all that mind space that they were going towards food can go towards these other things that they couldn't do before. So it's really nice.
That's amazing.
Fascinating.
Amazing.
Yeah.
So we mentioned a little earlier about testosterone.
Yeah.
So and we see it out on the internet. What is the relationship between testosterone levels, libido, and like erectile dysfunction with GLP-1 agonists?
Yeah. So recent study just came out looking at comparing testosterone versus tirzepatide. I'm sure I don't know if I sent it to you or not. And yeah, because I mean, you guys probably talked about this on the podcast, but kind of that male secondary associated hypogonadism,
Yep.
obesity associated
Absolutely.
hypogonadism.
Yep.
So like you said, if you get people to lose weight and that was the cause of their hypogonadism, their brain starts talking to their testicles again and things start revving back up. Now, the thing is, though, with these drugs, we see that people feel a lot better. There's some that don't feel better, especially at higher doses. And this is what I'm seeing. I think it has something to do with the dopamine effect, the reward center in the brain. So some patients lose pleasure of everything.
Correct.
And people are like, well, you're giving these anti-pleasure drugs to everybody. I'm like, no, there's a sweet spot. Some people go up to the highest dose and they feel fine. They lose a ton of weight. They're good. Other people, you get them up to the highest dose. They've lost a lot of weight. I just had a few patients. They're like, I think there's something up with my libido. I've lost like 20% or whatever his weight. He's feeling great, looking great, but his sex drive's gone. And I'm seeing this a lot. I see it in women as well.
Yeah.
I see a lot of anhedonia, just kind of like, I don't know. I don't want to do my hobbies anymore. I don't feel like going for walks. I don't feel like going to the gym. I'm like, well, that's the opposite of what we want.
Yeah.
So in these patients, I have to drop their doses down. Sometimes I add in bupropion because of the reward center dopamine effect that I see. So that's what I have to do. And once in a while, their testosterone won't go up, and but maybe there's some other cause of it. There's some primary versus secondary effect, and maybe it wasn't their obesity. And then those people, I'm like, all right, I'm gonna give you a little testosterone replacement. Do you want kids anymore? All that same kind of conversation that you guys do. But in general, we see an improvement. But there can be too much of a good thing, and that dampens down the pleasure center. I know it's being studied. I'm just seeing it all the time clinically, and so then you just got to drop them down.
No, it is something that I think I've seen, Kevin's seen. There's some data on the erectile dysfunction too. There's been retrospective analysis on that. And it is funny because it's counterintuitive in a way to what you would expect. What about the role of testosterone in these GLP-1s, though, in general? I mean, the assumption it gets better, but I think, like you said, there are still people that are going to need the supplementation.
Yeah, I mean, it'd be the same thing. Like, let's say their testosterone was over 200 nanograms per deciliter, and you're like, some of them aren't even symptomatic that low, and you get them down, and but if they are symptomatic, you're like, well, either you want to do both at the same time. It's up to you. They go, no, let me try this. And if it comes up, great, and they're feeling better, great. But if not, you're like, whatever, well, this is time to treat. I mean, the biggest thing that I always tell people, though, is like, look for some underlying cause. Like, what did it go?
Absolutely.
Make sure you're
treating the underlying cause. We're not just
crossing
putting
your T's, dotting your I's.
Not just putting a Band-Aid on something and not figuring out what's going on.
Like whatever, HIV, hemochromatosis that somehow didn't go diagnosed.
Yeah.
Like, oh my God, why is my skin bronze? I'm like, it doesn't
Well,
happen.
I don't ask that question in Florida, though. Everyone's bronze.
Once in a while. But, you need to get an MRI if it's really low. All that stuff that you guys, I'm sure, talk about. But I'll do both if I think indicated. I had a patient that was really upset that I didn't just throw him on testosterone. I was like, well, hold on a second. Your symptoms are overlapping with all sorts of things that could be going on. You just kind of felt meh. And I was like, this could be the medicine doing it. I don't want to throw the testosterone on top without trying to make sure that
Yeah.
because his testosterone's like 400 or something like that. I'm like,
Yeah.
and no troubles with libido or erection. He just felt fatigued. And I'm like, the medicine does that. So
Yeah.
sleep apnea does that. Can we just make sure?
100%.
He was mad. He left. He wanted the testosterone. I was like, sorry, man. I want to be a good doctor here.
Hey,
I'm
you
sorry.
gotta sleep at night. That's the
know.
bottom line. You got the next one?
Yeah, sure. Well, I think we're going to talk about. I think next we're going to talk about like who's a good candidate to go on it.
Yeah.
But you're a fund of knowledge. You have so much expertise on this. I wanted to get your thoughts.
You want the medicine.
Yeah, that's so on that note though, like you have all these. You go on TikTok. There's all these like biohackers. They're like, look, you got to like microdose GLP-1 agonists. You got to this is like the protocol you need to do. So what are your thoughts on like maybe patients who don't necessarily need it, who are already like in tip-top shape, and microdosing or using these GLP-1 agonists?
Yeah, like what's their intention? Are they looking for longevity? We don't have any data on that. If I'm going to be really bullish, I think in 5 to 10 years we're all going to be on a little dose, some dose, because I think it's going to be cardioprotective. If I'm being evidence-based, I'm going to say, hold on a second, we don't have any data for that.
Yeah.
And like, is it possible there's some weird smoking gun that we haven't studied in healthy people that like all of a sudden comes out? I don't know. The drugs have been out for 20 years. The newer drugs, have like 4 or 5 years of large randomized trials in those with obesity, though, and type 2 diabetes, not like kind of leaner, healthier people. What I always say, though, is that those rare potentially case reports that we see online that hasn't been shown in the data get magnified when everybody's taking it who doesn't need to take it.
Right.
Yeah.
So then all of a sudden we're on the stand. Your Honor, I gave it to him because he wanted a microdose, and they're like, but he got XYZ that we didn't even know about, and like, why'd you give it? There was no indication. So medical legally, and it just like, I don't even know what the risk could be. I think the risks are probably low if somebody's doing that. The thing to consider too is that when these first came out, they went out of stock. Like they couldn't keep them in stock. It was traumatic for both, obviously the patients, number one, but then the doctors patients were just yelling at us. We can't get the medicine. We're calling pharmacies around. Like nobody could get it. It was gone. So then they start regaining the weight. And it's because the Kardashians and everybody in Hollywood's taking it. There's concierge docs giving it out to people with like a 21 BMI who are just ripped, and they're taking the stock. So that was I don't think that's going to happen anymore. We have, I only prescribe FDA approved versions, but a lot of the microdosing people are using either gray market stuff that's not even, who knows where it's coming from. And then they're getting a lot of compounded stuff, and there's a lot of legality stuff there. I wouldn't prescribe. I don't know what's going into these things. But so I think at least they're alleviating the stock by going that way. I personally, it's like indications only, type 2 diabetes and obesity. Now, the thing is, the label used to say 30 BMI, kilograms per meter squared, or 27 BMI plus a comorbidity, which is hypertension, sleep apnea, any type of weight-related thing that happens due to your weight or adiposity, fat tissue. They've since removed the BMI criteria and are basically saying people with obesity, and then there's new criteria now for what is considered obesity. Like if a patient comes in, they have a 23 BMI, but they have like metabolic syndrome, they have some pre-diabetes, they have a little bit of elevated blood pressure, and they got a little bit of belly fat. I'm like, this person's a candidate. They have obesity, even though they look small, but they're holding most of their weight in their abdomen. So I wouldn't, obviously you're going to try lifestyle and stuff, but I wouldn't be opposed to giving, insurance probably wouldn't pay for it at that, but like I wouldn't be opposed to giving it. It's the people that are like straight up Hollywood that are using just a little bit of dose. I'd be like, man, what are we trying to achieve here? Like you're already lean and super healthy. The only thing that could happen is you get leaner and potentially it's possible for harm. Maybe it's healthy. Maybe it'll protect you from a heart attack in 20 years. That's why I think maybe I'll be on one in like 5 to 10 years. But I don't even know if we'll have the data by then to even think about it.
Right.
But
it could be 20-year data.
It could be.
Right,
But I know Big Pharma's going, they're sitting there rubbing their hands behind a tree, looking behind there. They're going, oh yeah, we're going to start studying this. I actually think it's going to be used. The perfect use case is the family history of obesity, the mom, dad, brother, sisters who are older. they're like metabolic syndrome, type 2 diabetes, and you got the youngest kid, let's say, who's a 25 BMI, and you start seeing their weights going up 5 pounds each year, and you're like, this person's going to get type 2 diabetes. So you put in the little bit of a Zepbound, or who knows what's going to be out. There's all sorts of new ones coming out, and you give it to them, just a low dose, and you prevent it from ever happening.
So interesting. Now, you keep mentioning BMI, and this is something that I've thought about, because obviously a big metric used is still BMI.
Your BMI was like 80 when you're a
my
linebacker.
BMI was probably like 100%. Dude. I was that was it. But how important is BMI? Like, is this an actual good metric for health and weight? Because I always thought it wasn't.
Yeah.
Because my BMI, you're right, was probably like 80%.
Yeah, it was so high. Yeah, you're a little meatball when you're.
It's true, dude. It's true. I'll show you pictures.
Over in Jersey, right?
You should see the photos.
It's terrible. That doesn't look like me.
Yeah. So BMI, the thing is, it actually correlates pretty well to like body fat. Like, most people aren't walking around like Ray Lewis or whoever, some linebacker from the NFL that had a BMI of 32. You just don't see it. It happens though, and you get people online going like, my BMI is high and I'm lean. I'm like, yeah, we're not talking to you. It's supposed to be used as a screening test.
Okay.
The doctor should go, all right, this linebacker's coming in and their BMI is 31, but their waist is trim, they're pretty chiseled, they have no obesity, they're muscular. You're supposed to assess muscularity too. Right. But when you look at the data, like, most people aren't walking in as an NFL linebacker. Right. And so it works pretty well. Now the newest definitions of obesity came in. They're actually adding like waist circumference, waist to hip ratio, and waist to height ratio. And basically, because you get these people with like a lower BMI who actually have obesity because they hold most of it in their belly, even though they don't weigh a lot overall.
Yeah, like those pregnant looking guys.
So the newest data, because with the BMI, it's around 40% of people have obesity, just based on BMI. It might be a little bit less based on the muscular folks, but like again, it's actually quite rare when you look at how well it's in the 90% of most people are like, yeah, this person's got obesity if their BMI is that high. When you add in this new data from the waist circumference, that prevalence starts going up to more like 70% of people. So most people walking around could lose some pounds, and we all know that.
Yeah.
But like, when you look at somebody like, oh, they no obesity there. Well, technically they have. Someone could be larger and kind of store it in their legs, a higher BMI, but
is it fair then though? Like, is it fair to call these people obese? Do you think? Like, do you think it's fair to call those 70% of people obese? Like, obviously, and this is just an interesting thing because a lot of people now, there's this like fat shaming thing.
Yeah.
And like, obviously, so like, is it fair to call someone obese? And like, I just don't understand how to categorize.
Yeah, it. So you would call that anthropometrically obesity, meaning from numbers, from measuring the body, obesity. They've gone further in talking about now what's like clinical obesity, meaning does somebody have dysfunction, not just extra adipose tissue, but do they have a little bit elevated blood pressures, blood sugars, knee pain, issues from their weight metabolically or physically. So we're really trying to like go like, okay, then everybody's got obesity.
Right. Like, what's the point? If everyone has obesity, it doesn't really matter.
Yeah. So they're trying to classify and stage them in different ways that hopefully make it a little bit more nuanced. But like when somebody comes in the clinic, you really got to assess them going like, okay, this person's got a 27 BMI. They're in that overweight category, but they're pretty jacked. Like, you just gotta, it's a starting point, screening thing. Then you gotta assess them further. So I don't know. Yeah, what's the point? Everybody's just screw it. Everybody just takes the medicine and whatever at this point.
Yeah.
All right. So for our listeners, can you tell them like what are the biggest misconceptions out there about GLP-1 agonists?
Yeah, I mean, like I always say that they're a crutch. I mean, some people are like, well, no, crutches are good. It helps you get going. But I say a crutch because usually crutches are only temporary. I would say it's a chronic disease medicine, just like any other chronic disease medicine. So that's probably a big misconception. I always say like the easy way out. It's not the easy way out. You got to get an injection. You got to use it, and then you still, again, for the people that really hone in, they're still putting in a lot of work. there are some people that don't put in the work. I'd be lying if I said, no, everybody taking these, putting in. That's not true. My patients, though, I've been like, you're going to work now. I give them all the tools. I mean, and I'm a selection bias. People come because they're like, oh, this guy lifts weights. I'm all into that. I'm going to come to that.
Yeah.
But I there's got to be people out there. I had a patient when I was in practice before I got into the whole telemedicine and making my own clinic and stuff. I always tell the story about it. There's a patient came in and we had him on phentermine. They got bariatric surgery. I put him on liraglutide. I put him on all sorts of drugs. And, and she said, like, that she wasn't losing weight. And I was like, well, what are you doing? She's like, well, every time I go to the pharmacy, I get a candy bar and things like that. And so, I sit back and go, like, all right, is this person putting in the effort? Like, does it matter though? I'm going to still treat them regardless. Right. Or is it that food addiction that even though I'm giving them all sorts of drugs to hit the receptors, it's still tough. So it's not fair for me to just judge them and say no matter what they weren't putting the effort. Maybe they were, but there are people out there that probably don't, and who cares? We don't judge. Even if somebody's taking insulin, you'd be like, I'm going to withhold this insulin because you're not eating well.
Yeah.
Can you imagine that? I'm not going to give you your insulin.
My God, so many people.
I'm not going
to. Many people. Will be
so anybody listening, not type 1 diabetes, type 2 diabetes,
Yeah.
where they've developed so bad of insulin resistance, their pancreas is burned out a bit that they need insulin to keep their blood sugars at least close to normalized. But withholding insulin, that would be unethical. So withholding these GLP-1 medicines just because I'm like, you gotta go lift some weights, you gotta eat better. That would, that's the morality behind obesity. And so I'm always like, whatever. I mean, I can't force you to put an effort. I want you to. So I would say though, for the majority, it's still not an easy way out.
What is your stance? You're on TikTok, you're on Instagram, you're all over these things. These natural GLP-1s, it's all over the place. It is just people selling this shit. I don't know if it's shit, actually. I'm just saying.
No, it is.
Yeah, there you go. Because I mean, we see it for all this bullshit stuff of random people on TikTok cutting a banana, telling me how they're going to lose weight based off of some bullshit thing that they're buying, and it's going to increase their testosterone as well.
Oh God.
So what's your stance on all these natural GLP-1s?
Yeah, they're just jumping on the market, and they're preying on the people I was just talking about, who they're looking for some sort of hope.
Yeah.
They're looking for an answer. Yeah. They can't afford the medicine. That's why it's not an easy way out. They gotta actually go and effort and get this medicine and inject themselves and all these different things. So these natural GLP-1s, they're just jumping on the bandwagon. They will these people want to make money. They're not doctors. They can't prescribe the medicine. Not that doctors get money for prescribing this medicine.
Well, it's also very important to understand
people think that. They're like, you're promoting Ozempic. You get kickbacks. I'm like, man, if I got money,
you would have retired
I would have retired a long time ago because I prescribed the hell out of these drugs. Yeah, no, they're jumping on this to make some money, so they're coming up with little things. So, for example, I just did a video on unfortunately, I think she was a dietitian. I don't know if she was actually credentialed or not. She called herself a dietitian. And she was like, black and green tea increases your own natural GLP-1. Okay, yeah, there's a lot of little things that can increase her natural GLP-1. Like I said, it gets broken down so quickly. And then she was like, but it actually helps it keep around longer. Well, in mice, there is some data on black and green tea blocking or inhibiting a little bit of the enzyme that breaks down our GLP-1. So it's like, wow, magic. Except then when you look at the data with black and green tea with glycemia or weight loss, it's very small. So it's like, this isn't nature's Ozempic. It barely does anything. Even it has a tiny little mechanism that may modify, and who knows if those studies in those rats was even crosses over to humans or not.
Well, that's the problem, right? You can find a paper on almost anything that supports your idea, but the problem becomes when you're a patient, when you're a person who doesn't have the understanding or the background, you hear someone quote a paper and you're like, okay, this is legit, but
this is lore.
This is true, but you have to understand who's giving you that information, why they're giving you that information, and the
limitations of whatever it was.
Correct. For sure.
So there's no nature's Ozempic, nothing. I mean, nothing. I mean, if it worked, we'd all be giving it to our patients.
I'm on it, dude.
Yeah, we're not trying to hold off on any of this stuff.
Yeah.
All right, so this space is it really is amazing. Over the next 5 to 10 years, it's going to evolve so much. So just want to kind of get your thoughts on where you think this space is going to go. You know, the stock market, they're saying like is counting in like no one's going to be overweight in the next 5 to 10 years. You're seeing these fast food restaurants. So like
Yeah, the Ozempic meals.
the Ozempic
Yeah,
meals. So
yeah.
like you know, is that where we're going to be?
I'd give it more like 20 years, but in a few years, there's going to be some just extremely powerful drugs that are out. And if those drugs are going to be like hitting like 30% total body weight loss, you've probably heard of retatrutide or retatrutide. It hits 3 receptors as opposed to the 2 with tirzepatide. And like I've had patients that are in the clinical trials and now they're coming over, and it's just the result is ridiculous. That people are going to be walking around skeletons, I think. I don't know. But like if that's only this in a couple of years, what it's going to be out in 10 years, 20 years, I have no idea. So what I think they have to study this, because you never know. Once you start adding on receptors, it starts all over again with the process of like, is this safe?
Yeah.
We know GLP-1. It's great. It's awesome. Everybody should be on a GLP-1. Or we know any GLP-1 that comes out, for the most part, there are some that don't make it to market because there was some offshoot effect that you didn't see happening. But for the most part, GLP-1 agonism is good. But yeah, the glucagon on GIP looks to be safe too. But the glucagon, you start adding on whatever else they're going to start adding onto these medicines. You got to study it closely. But I think when you hit multiple different receptors and assuming they're going to be safe, we're going to see just crazy things happening. So I think a few things. We're going to see these drugs used for primary prevention, for cardiovascular disease, and for all of metabolic disease. I think they're going to, in our obesogenic environment, people are like, why aren't you talking about fixing the environment? I'm like, how are you going to do it? I don't know how are you going to do it. And they're like, well, big food's in bed with big pharma. I'm like, no, big food probably hates big pharma for these drugs because people are going to be eating less of them. Right. And so I think we're going to prevent obesity. I think we're going to I do think over the course of 20 years, if they become affordable, that's going to be in one thing. If it's just $1,000 and the Kardashians or whoever can afford them only, then it's the divide of our socioeconomics it's just going to be larger. And so that's going to be it's going to be seriously it's going to be worse. It's like all the rich people can afford these, wealthy people can stay thin, and that's why the South Park that came out about it was like, you get Lizzo and you get Ozempic, whatever, and it's just it's actually true. That's why it's
they're so
it wasn't even funny because I was like sitting there going like, damn, this is like too close to home. So I do think if they're affordable, a lot of people are going to be taking them, preventing obesity, preventing cardiometabolic disease. And newer versions are just going to get better and better tolerated. Other indications, addiction, psoriatic arthritis, and other inflammatory disease processes that we're seeing benefit. I don't know. The future is very bright. We just got to get away from this duopoly of Novo Nordisk and Eli Lilly, because we got to get multiple. We got to get Pfizer in there. We got to get these new startup biotech companies jumping in. Someone's got to undercut. Get rid of the compounding places that are just trying to siphon off these off the tit of these the technology that these other places have developed, and just start evening the playing field in terms of money. That's what I think we need to do.
Do you think that bariatric surgery is going to be obsolete in the next 5-10 years?
Not 5-10 years. I do think in 20 years. Then they get so mad, and I'm like, look, right now it's kind of like oncology, where you got the oncologist and you got a surgeon, but like I think there will always be a place for bariatric surgery, because at some point some people may not respond to these drugs, but maybe they will though. I don't know. It's possible we find drugs that just it doesn't matter. You might as well just take the drug. It's so cheap, it's safer, and will prevent cardiovascular, all these different things that you didn't see with the surgery, and you don't have to get cut. So I'm not going to say 5 to 10 years, not going to happen. I would say 20 years though. We're already seeing it. Bariatric surgeons are like, we're all the patients, and because they're like, I'm just taking the drug. But we're not at that 30% level yet on average, like bariatric surgery. But I do think it's not. I see it happening. It's happening in the next few years.
I think you wanted to ask a question about who's prescribing this, right?
Yeah, pretty much everybody.
Yeah. So, Justin and I were talking about this. So, prescribing GLP-1 agonists, do you think anyone can. So like I'll say, like, let's say Justin and I, we've, there is some little bit of overlap, but I'll tell you, we're kind of like we don't know enough. That's why like this conversation has been actually fantastic for the listeners, but also fantastic for us.
Right.
So like, do you think that there should be only certain docs or like practitioners to prescribe this because they're doing it the right way?
Yeah, it's a good question. I mean, the thing is, you see primary care doctors, like it would be like saying testosterone can only be done by endocrinologists and urologists.
Right.
Yeah.
But primary care doctors should be doing, should
A
be
lot
able
of
to
this.
do
Yeah,
everything.
100%.
Yeah.
Why is the endocrinologist seeing somebody for hypothyroidism? I'm always like, when a patient comes and sees me and I'm like, oh, you're on Synthroid. Oh, I can take that over for you. Who's doing it for you? And they're like, oh, the endocrinologist. I'm like, why would you see an endocrinologist for hypothyroidism? That's like, they should be reserved for, thyroid cancers and pituitary diseases, Cushing's, and all these different, like, really, relatively rare, harder to screen for and test for and treat for disease processes. So the problem is everybody's jumping in on the GLP-1.
Yeah.
I saw anesthesiologists. I see
Right.
dermatologists.
Hey, we're in the T space. We hear you, right?
Yeah, oh yeah. I
Same
mean, you
thing,
guys
dude.
see ER doctors giving testosterone.
Yeah,
Like
100%.
you came in for a headache. Here's some testosterone. Come see me at my clinic. Get jacked. And so the thing is, we're seeing a lot of that. I hate to gatekeep these medicines. Like people, some insurance is like, are you an obesity doctor? Because you should be the only one prescribing. I'm like, motherfucker, I've seen some really dumb shit obesity doctors doing all sorts of crazy stuff. You don't want them just to do it. As much as I'd like to say, obesity, we can be the only ones doing it. Unfortunately, I've seen, it's just good. Like, if you're a good doctor and you have follow-up plans, you can follow them. Like, if you guys are able to follow people and make sure they're not losing weight too quickly and titrate appropriately, it would be reasonable to go like, hey, weight loss is a good option to start with. Maybe here's some Clomid or clomiphene, maybe testosterone, but like GLP, like it makes sense. That's why we're starting to see blending of all the cardiometabolic model of like who's in charge here. There's even nephrologists, and then there's hepatologists, and then there's cardiologists, endocrinologists, and then the primary care doctors are like, well, wait a second, like cardiologists are now getting into these things. Before they're like, oh, weight loss, whatever, but now it's like, oh, these things are cardioprotective. Wait, this is our thing now. And the thing is, it's hard to. I think everybody should be working together, but like it's a money grab kind of thing.
For sure.
Yeah, I mean, I think that especially in our field when we're talking about weight loss and fertility and improvement in that space, so like I'm not saying I don't think there's great data out there, but it's some stuff that we start thinking about. This is completely out of the blue. Like, this is just a question that I think I hear a lot. Like, a lot of patients come in, especially in the longevity space or this weight loss space. They come in, they're like, I need an IGF.
Oh, yeah.
I'm like, okay, I don't really know. So can you give us like what should patients be getting an IGF?
No.
Like what does it mean? Does it mean anything?
Yeah. I mean, the thing is, so I'm technically family medicine. My brother does endocrine, but like because he and I talk about this all the time because we see it all the time. It's growth hormone deficiency. You're looking for, or I mean, like I guess you could be looking for acromegaly and stuff, but like you're searching for pathology. You don't screen people just randomly for their IGF-1. That's not something that has any indication or anything that, like, I saw someone in these Facebook groups, the testosterone Facebook, and I'm like, what are these people doing? And someone's like, how do I optimize my IGF?
I get that all the time. I get this
and you're
all
like,
the time, right?
For what? What are you gonna do? It doesn't.
Like,
it has
I don't know, dude. I don't know.
It has nothing. Like, what are you gonna try? So then they're gonna try some Morlin or whatever, some of these secretagogue type of things, and it's like, man, just have a better lifestyle. Don't be looking at fucking this other nonsense that just has no indication. So I mean, really, it's like growth hormone deficiency. That would be your reason, but that's rare. People shouldn't be just randomly testing it.
I'm going to ask because there was a tweet I saw yesterday, and it's just kind of in my circle now of friends that are not doctors who always ask me, and it's like this coronary artery calcium score.
Oh yeah.
And they're like, you got to get it. You got to get it. And then they'll ask me to like, doc, you got to get it. And I was like, that's a little bit, I don't know enough about it, but I guess it makes sense. But like, insurance doesn't cover it for the most part. If
no,
you don't
it's
have
like $150 out of pocket.
But
usually.
all my buddies are just like, oh yeah, I just paid $150,
Yep.
went in, I'm a zero, I'm solid. I'm like, okay, great.
Yeah,
But,
sweet. It's supposed to be used for those at like an intermediate risk where you're going, do I need to treat this person aggressively with a statin or other
Right.
lipid lowering therapy versus maybe watchful waiting. So say somebody comes in, and in general, young people, we should be a zero. If we're not a zero, then you're like at really high cardiovascular risk. But some people believe these are going to be like mammograms of the future. But the problem is, just you get incidental
Yes.
Like, for example, I appropriately tested a couple of patients, and then they had some lung nodules that I'm like, oh God, now I got to do it every 6 months now for the next year or so. I got to repeat these CTs, and now they're getting more radiation.
Yeah.
So you got to make sure it was in it. And luckily, those people, it wasn't just like, oh yeah, sure, get a coronary artery calcium score. And now I got to load them up with more radiation for downstream testing. So it's supposed to be intermediate patients where you're on the fence of like, should I treat them with a statin or other lipid lowering therapy? So for example, let's say a 50-year-old, it could be a woman or a guy, and their cholesterol is like, let's say their LDL cholesterol is like, 148 or something like that, and they're like, I don't really want a statin for this. They maybe have a little bit of a family history or not, but you're just like on the border, and you go, look, let's get a coronary artery calcium score. At least if it's zero, we know your risk. Your risk isn't zero, because some people have like soft plaque. It won't show. It's calcified plaque,
Right.
which it's a good correlation, but it's not perfect. So if it's a zero, they're at a pretty low risk. But if it's positive, and they have different levels of and percentiles too, depending on the person. But if it's high, you're like, we got to be aggressive. So for example, I had a patient like didn't want it. I'm like, even though you're like, you could just go like, let's just treat you aggressively. That's kind of that primordial primary prevention where you're like, well, who cares about the calcium score? Let's just get your risk factors down. But some people are like, they don't want to take medicine. So that's what you do. I had a patient that didn't want to do it. Their calcium score was quite high. And I was like, okay, now I'm actually going to treat you more aggressively than I probably was going to treat you, even without this calcium score. So it's really, you don't want to do it on everybody. You want to be appropriately testing people. It's the
Is there an age, or is it more of is it more like a health, like you see a comorbidity?
Yeah, it's in general, in your 40s, you start testing it. Some people, you can test them a little bit earlier, but we're assuming it's going to be zero. If you're in your 30s, it should be zero. And if you do and it's positive, but like in general, it's more in the 40s that you start doing it. In intermediate risk folks, like if somebody's low risk, you could do it, but then you're at risk of downstream effects of like getting further testing. And I had a patient had like they needed to get an MRI because they saw something, or got it CT because of, I think, the lung nodule. Then on the CT there was something on the liver. And then they had to get a biopsy. It was a whole thing. Luckily it was benign, but it was like, that's what happens. Like when you start ordering things, luckily I had a pre-test probabilities and had direction. It wasn't just like, yeah, everybody's going to get one. But I'll never forget some of these cases. And it doesn't mean you shouldn't be doing it at all. Just try to be appropriate, because, if you test everybody for testosterone, all of a sudden somebody's going to have a 250. They feel pretty good.
Yeah.
Yeah,
and
no,
now,
it's true.
And now
It's
they're
true.
going to be like, I need some
Yeah.
testosterone.
Yeah.
That's true. Dude, this was awesome. This was really
great.
phenomenal stuff. Thank you so much for coming on. Tell our listeners where they can find you, how they can follow you. I'm sure they're following you already.
Yeah, well, I hope so. Jeez. So Instagram, Dr. Nadolsky. I have a Docs Who Lift podcast with my brother. He's an endocrine and obesity doctor. We talk about fitness, GLP-1s all the time. We got all sorts of other people on our pie. We'll have to have you guys on at some point. Threads, Dr. Nadolsky, TikTok, Dr. Nadolsky. And then I have a clinic, myjoinvineyard.com, where I schlep out GLP-1s all day. But we try to do it appropriate. You get a dietitian, you have a strength program and everything with it. Anything you'd ever need along with your weight loss journey.
Awesome, man. Thank you so much.
Yeah, thanks for having me on.